to turn it back to you, Dr. Preeshagul. Someone asked a really good question about CNS, and you mentioned that when you see CNS sort of cohorts open for patients with EGFR on trial, you get excited. I get excited as well. This is a significant unmet need for our patients. So what's your opinion on this pulse dose of afatinib, a second generation EGFR TKI, and osimertinib, a third generation EGFR TKI, specifically for patients who have leptomeningeal disease, so cancer involving the lining part of the brain? And so comment on that. And then also, what are some other strategies that you've looked into for leptomeningeal disease in this setting?
So, as I had mentioned, patients that harbor EGFR mutations have a very high propensity to develop brain metastases, whether at diagnosis or whether down the line their treatment course. So, pulse dose or higher dose or even double dose of these tyrosine kinase inhibitors has been explored. I know there was some data that was presented at ESMO a couple years ago, looking at osimertinib given at the dose of 160 milligrams a day instead of the standard 80 milligrams a day. And typically between afatinib and osimertinib pulse dosing, I typically tend to lean a little bit more towards the osimertinib pulse dosing, and that's simply because toxicity. Afatinib alone compared to osimertinib is a much dirtier drug. The diarrhea is legit. I don't have to tell you that. If you've been on it, it's awful. And if we have a drug that's also efficacious in this setting and has better toxicity, why not try that? So that's my reasoning there. I definitely have used what we affectionately call double dose OC before for my patients that have leptomeningeal disease, or for someone that perhaps is on osimertinib at 80 milligrams and has just progression in the brain. And maybe is not interested in chemotherapy, not a candidate for radiation because they've previously received radiation, older and, not interested in IV chemo, or doesn't meet criteria for a clinical trial. So I would definitely believe double dose OC is effective for the right patient, but it is more toxic. And it is definitely it's not easy.
Yeah, I agree. I think, CNS metastases, leptomeningeal disease remains a really high unmet need. And we are looking at therapeutics that have, better CNS penetration, but really it's targeting that resistance clone in the CNS as well. Osimertinib, right, a third generation EGFR TKI has great CNS penetration, but if you lose activity of the drug, you really need to think about a different strategy.